I encourage you all to submit your questions via your device if you could. Anyways, Dr. Ellis, as you're thinking about those cases that you go back and look at after initial surgery by another physician or maybe even a surgery by yourself, do you typically go back and hook or actually lay eyes on the previous muscle?
Yes, Jeff, actually I go a little, I'm usually doing fornix incisions, and I usually do put the hook under the muscle, and I will clean off the insertion so I can get an accurate measure from the limbus. One of my partners, Sprague Eustace, measures transconjunctivally without actually cleaning off the insertion. Is that the answer to your question?
Yes, and then let's say you go back and then in your surgical plan on dosing, you find out that when you hook that muscle and clean it, it's only 50% as wide as a normal muscle, or maybe even 25% the width of a normal muscle, and it's lost a lot of function. How does that influence your dosing and surgery?
Great question, and that's why this is magic, right? So I will look back further along the insertion and see what the belly of the muscle looks like, because often that muscle is slipped within the capsule, or else there's some poor adhesions to the sclera from that. So I'm looking to try and find a good piece of muscle and bring it back up to that spot, and then I'm also checking the forced ductions at that time. But I don't know, this is where, I don't know how I decide what I'm going to do, but usually it takes some additional recession or a little resection or maybe a combination depending on how large the angle is.
One comment, to ask questions, the instructions are on page 11. It's Roman numeral XI in the meeting guide. And it takes you a few steps to get to the ability to ask, to type it in, but it's actually not that difficult. So just follow those, and then you can enter your questions. So one of the audience questions here was, when you re-recess the medial to 12 millimeters, are you concerned about adduction limitation and consecutive XT? So really, what the impact of re-recession is on motility.
So the answer, Mike, has to do with what's been done to the lateral. So if the lateral's been resected already, then I'm a little more cautious about how much re-recession I do. But in general, if you're back 12 millimeters, then that's 6.5 from the original insertion. I don't find that I have any limitation of gaze in that situation. And I will say that I maximize the amount of recession by minimizing the amount of resection when I put my sutures into the tendon.
George, here's another question from the audience. Do you have any tips for dealing with scarring of the conjunctiva when you're doing reoperations?
Care and careful dissection. Again, I usually am doing fornix incision, so it's usually me separating the scar from the original insertion to the conjunctiva and the tenons with blunt dissection using Westcott scissors. Sometimes, if the conjunctiva has been recessed previously, it's a little more tricky. But it usually, if you're meticulous in what you're doing, that's the way I usually do it. Now, there are those situations where the scarring and the recessed conjunctiva is so far posterior that I'll opt now for more like a swan incision to get to that muscle.
George, here's another question along those lines. With these large recessions, with these large re-recessions of the medials, as you follow these patients for a long time, over, for example, 10 years or so, are you noticing that they're leading to late overcorrections?
That's a very good question, and I was talking to Dave Staker Jr. about that, and if I've done what amounts to a 7, so now we're going back from 5.5, 12.5 millimeters back or larger than that, especially if they're bilateral, I am seeing late overcorrections. But it's like the 10-year, 8 to 10-year time. It's not in the first 3, 4, 6 years usually.
George, here's an interesting question. Do you routinely do testing of convergence amplitudes? Or, what are the situations that you might do that, if any?
So I do use convergence amplitudes. You'd have to have fusion to do convergence amplitudes of any significance. So if I have a patient who is, especially an adult that's diplopic, yes, I want to know their fusional amplitudes because that helps me determine the target range I'm aiming for.
George, if I can ask one last question, because we're running down the timer. You mentioned exploration of previous surgeries, if you didn't do the surgery. I'm curious, I find that the longer I practice, the fewer explorations I do, because I find I don't discover as much that I wouldn't have known from examining the patient. How often is it that you discover something in exploration that you wouldn't have known?
Often, I think. I do understand the Cooper's dictum and kind of ignore what's already been done and do what you think needs to be done. But if somebody said that they did a 5mm recession and I don't go explore it, I may find it was set up at, instead of I'll see it at 6.5 or 8 instead of back at 10.5. That's often what it is, and I think that happens more commonly when the first surgery was done when the child was young, less than 2-3 years of age. The way the eye grows and the way the muscles, I don't know, quote unquote, migrate, but I often find that they're in a different place than we expected them to be.
Thank you, Dr. Ellis.
Thank you. Enjoy your box water.